Good morning, everyone. I am just making sure we're officially live. We are. Good morning and is it Thursday, I think? Welcome back to our series on for MHAM. If you haven't seen any of our videos yet, we were doing this week. This is Migraine Headache Awareness Month. And so this month with American Migraine Foundation, we have a theme of I am visible. And in my short time at American Migraine Foundation, so many people have said this is an invisible disease. And so I'm so excited today to continue in this path and this conversation by welcoming Dr. Stu Tepper. Dr. Tepper, welcome.
Thank you. It's a great honor to be here.
Well, I don't think many people need an introduction, but will you tell people where you reside and what your practice is?
Yes, I practice at the New England Institute for Neurology and Headache with Dr. Peter McAllister and Dr. Kate Mullen, and I'm also a professor of neurology at Dartmouth.
Well, just a few small accolades there behind your name. So, welcome. Thank you for being here. And we're going to talk about something today that the term is a little complex sounding, but I want to bring it back down for people who may go, I don't know what that is. So, we're going to talk about rational combination therapy. Start at the beginning. What is that for patients who may be new to that phrase?
Our therapies will often work in one way only. What we say is they have one mechanism of action or one target. And our clinical goals as headache specialists has changed pretty dramatically. And in earlier this year, the International Headache Society published a goal for clinical treatment for people to get them migraine free, not just to reduce the number of headache days in a month or the amount of headache free time, but really get people to where they forget they have migraine.
Mm.
And that has been my goal for clinical treatment for a while, but I love the fact that they put it all together. And what that means in practical terms is if somebody has a treatment and let's say it works 50% or 80%, that's not good enough in my judgment. We really need to do better than that because I want to hear those words. I want to hear, oh, I forget I have migraine. And in order to do that, we often need to combine different targets, different mechanisms of action, different therapies, whether those be multiple medications, medication plus neuromodulation, as needed, and preventive treatments. That all of that is incorporated in the term rational combination therapy.
Well, I think first of all, you've had a lot of people at less pain days and 80%, like I think, or more than 80%. I think people were going, I mean, I know that gives me pause to go, wow, what hope that is if someone's watching this and they thought, this is just my life. I'm just kind of stuck. This is what the doctor said to do, and this is for the rest of my life. So, first of all, thank you for even providing that type of hope to people watching who just may be kind of frustrated with what's happening and how they're feeling. As a clinician, what criteria do you use to determine when to initiate combination therapy?
Well, let's take an example. Actually, we can talk about it on two sides. We can talk about it in preventing migraine. We can talk about it in the treatment as needed, the acute treatment of a migraine
Hmm.
attack. On the preventive side, we've always talked about moving people from chronic migraine to episodic migraine, meaning taking people who have 15 or more headache days per month and putting them below 15 or more headache days per month so that they start to have individual attacks rather than a continuous kind of headache nightmare.
Right.
But and what would happen is we would initiate a treatment in a person who had 24 headache days per month, and they would drop, and the treatment would drop the number of headache days down to 12 headache days per month. So that was a 50% improvement. They had gone from chronic migraine to episodic migraine, and a patient who had that happen after years of frustration would be very, very, very happy and say,
Right.
"Oh, I'm so much better." And now what I say is that's not good enough. 12 days of headache a month, not good enough.
Hmm.
We need to put another treatment on top to try to drive the number of headache days down until you say to me, wow, I rarely have to take an as needed treatment. I forget I have migraine most of the time. Now, in the old days, meaning a decade ago, we only had preventive treatments that were invented for other disorders and had modest effectiveness and had lots of side effects. And people really disliked these medicines, fill in the blank, amitriptyline, topiramate, propranolol, and so on. But now we have a variety of medicines, most of which were designed specifically for migraine, that have different ways of working that we can add together without paying a price in terms of side effects.
Mm.
The term we use is there's no therapeutic penalty. That
Mm.
is, people don't get a lot more side effects when you add them together. And yet the combination drives the treatment down. So, for example, somebody is got has chronic migraine and is on Botox, which is FDA approved for chronic migraine, doesn't have a lot of side effects, and moved from 24 to 12 headache days per month and is thinking things are pretty good. Well, we can add an anti-CGRP monoclonal antibody, of which there are four, to the Botox, or we can add a GPANT to the Botox as prevention and drop the number of monthly migraine days down really quite significantly below where they are. And we have hundreds of patients now in case series that have been published about the reliability of doing that without seeming to pay a price in terms of side
Right,
effects. So
right.
that's how we do it. And I can talk to you about how those medicines work together, but suffice it to say, they work slightly differently and they complement each other.
So, what do you do if you're seeing a doctor? And this is in no way, shape, or form to say old school doctors who want to use one medication, this is no good. You should quit seeing your doctor. But if you are on the same medication for year after year, and maybe you've been on it for 20 years, and we won't even name which one, what do you do if your doctor just goes, yeah, let's refill that? This is what you're taking. It seems like it's your headache free, maybe 12 days a month. Or you're down to 12 headache episodes a month. What do you do about approaching your doctor to say, hey, I think there's better options? How does somebody go about doing that?
I politely disagree with you. I think it's time to get a doctor who works in the 21st century. I think it's time to move
Yeah.
and find people who are sympathetic to you as a patient, but also are knowledgeable and are setting the bar where we want to set it at migraine freedom. And I didn't even get to the acute treatment. We talked about as needed treatment. Let's say it works 80% of the time. That's not good enough. That means a fifth of the time you're not functioning properly within 2 hours. And you can switch the category of acute treatment, that can be done, or you can combine acute treatments. And that can mean taking two medicines at the same time or using a combination tablet. For example, the FDA approved a combination tablet that is supposed to be released and available this month, which combines an anti-inflammatory with a triptan as a combination, because we know that triptan plus anti-inflammatory is more effective than either alone. Or one could use a triptan or an anti-inflammatory on top of a GPAN. So again, different mechanisms of action allow for greater reliability in getting pain free within 2 hours without side effects. And in answer to your question, getting back to your question, I don't think there's a lot of choice. If you have a practitioner who is wedded to the old ways and does not want to come into the 21st century, you're going to have to look in your area for somebody who is knowledgeable and willing to help.
Yeah, I think sometimes people just need that permission. I'm from originally from the rural South, and you've got a handful of doctors, and everybody's like, this is who we see. And while they were fantastic doctors, there are areas of the world that you may need to say, I need to probably see an expert. Like, this is my life. I need to take back my life. I need to take back how many pain-free days can I have? So I think there's kind of a permission that you've given people to say it's okay. There's some great treatments out there. Do you think we're going to start to see more of those combination medications over the next 5 years, 10 years come into market?
It's possible. This gets a little bit inside the beltway, but the FDA has a pretty high bar for combination medicines. And what the FDA requires is that a company that wants to release a combination medicine has to do a trial of the combination as one arm in the trial, placebo as a second arm in the trial, and then the individual components of the combination. So, for example, the medicine that was approved in January has a special form of meloxicam, which is an anti-inflammatory, and rizatriptan. And the company had to do two studies with the combination, and one of the studies had to have the combination, and then patients were given meloxicam as a second arm and rizatriptan as a third arm and placebo as a fourth arm. And that is a pretty expensive proposition with a very large study. And so I'm not sure there are going to be further combinations. I think there are likely to be new formulations of older medicines. There probably will be new medicines and new targets that we can use in combination, but the combination tablets are few and far between.
That makes complete sense. That has to be incredibly complex, and we're grateful that there's a company that took that leap to try that. Because I imagine, as you describe it, I'm thinking that is super complex.
Yeah.
That makes sense. You talked a little bit about neuromodulation devices, and at the beginning, like different ways you could combine therapy. Talk a little bit about how do those play into the combination approach?
The FDA has cleared seven non-invasive neuromodulation devices. These are portable devices. They work by different mechanisms. Most of them are cleared by the FDA for both the as-needed treatment of migraine and the preventive treatment of migraine, both. So they have an advantage in that regard over most medicines. There is one medicine that has an FDA approval for both acute and preventive treatment, and that's rimegepant. But almost all of the non-invasive neuromodulation devices have that clearance. And these uh, devices also almost all have an FDA designation as non-significant risk devices, meaning they don't have significant side effects at all. And because of that, and because they don't cause drug-drug interactions because they're not drugs, one can use them either alone or in combination with fill in the blank, a preventive migraine medicine or an acute migraine medication, as needed migraine medicine. And what really limits us in terms of using them and integrating them more aggressively in practice, and I use them a lot, is cost and the fact that our payers have been resistant to covering them. We have a few that have coverage in certain areas of the country. A few of the devices have coverage in certain areas of the country by certain payers. The VA has been way ahead on this and covers almost all of these devices. So if you're a veteran, these neuromodulation devices for headache can be incorporated in your care and covered. Uh, and they're great. And I think that they can really extend the opportunity for patient improvement.
I love that. Just if you happen to be a veteran and you want coverage for that, do you just call your the VA, your primary care and say, "Hey, I heard this could be a potential for me," if the VA hasn't mentioned it to you as a vet?
Yes, you can do that. There is a national set of VA headache centers of excellence. And the neurologist who runs them, Jason Seco, who's a saint, has expanded these VA headache centers of excellence, and he tries to get them so that veterans can access them in many, many, many regions of the country. So if you have a VA headache center of excellence within striking distance of where you live, you can ask your primary care practitioner at the VA to give you a referral to the VA headache centers of excellence. and the practitioners at those centers are probably pretty knowledgeable about the non-invasive neuromodulation devices.
That's wonderful. That's wonderful. We'll make sure to put that in the comments as well, because I want to make sure people know when services are available that they may not have heard of or may not even be aware exist.
Right.
So thank you so much for sharing that.
I just want to add
Please.
that at one of the non-invasive neuromodulation devices is now FDA cleared down to age 8, and it's currently the only therapy that's FDA cleared for prevention of pediatric migraine. There's no medicine that it currently has FDA approval for the prevention of pediatric or adolescent migraine, and this device, which is called the remote electrical neuromodulation device, is FDA cleared and is pretty affordable. So I reach for it first in adolescents and children because the older treatments failed in a very large multi-center federally funded study. And so we really don't have reasonable prevention for adolescents and kids. And this device, which has the brand name Nerivio, is effective and is FDA cleared. So there's a large unmet need in adolescents and pediatrics. And there I go to the neuromodulation device first.
Yeah, yeah, absolutely. And one thing I'll share too, and again, we'll put these things in the comments, is that we have a device corner now on our website, and it has several devices and videos linking to to help you understand the devices. So it's not, it doesn't have all seven of those. I believe you said there were seven, but it has some of the ones we have people ask about often. And so please check that out. We'll make sure to link that as well. But that's so encouraging for families. If you have someone under the age of 18 and you want them to get this device, is that also as simple as telling your primary care or your neurologist in case they haven't heard about it?
Well, the problem is that each of the devices has a different way of prescribing. Many of them require the practitioner to fax in or electronically send in the prescription, and then the patient has to pay out of pocket for them. So you have to have a pretty motivated headache doctor or practitioner to access them. We try at the American Headache Society to integrate education about these devices, as you're doing on your website, for the practitioners who come to our meeting or who get education through our website in order to explain to them how you get these devices, how much they cost, and and where they would be appropriate. And we really try to encourage our attendees to incorporate them in practice. The problem is, as I say, you have to have a pretty motivated practitioner because each one is prescribed differently. There is one that doesn't even require actually two that don't require a prescription. One is called Cephaly and one is called Hedaterm. And those you can actually go online and purchase yourself, and they are non-significant risk devices. And in the case of Cephaly, approved by the FDA or cleared by the FDA for both preventive and acute treatment of migraine.
Yeah, that's wonderful. It's wonderful to have these options, and especially something that has low risk as well. I'm sure is music to a lot of people's ears who are like, I'm scared. I don't like side effects. I don't know really even know where to start with these. So that's fantastic. You started, and I could sit and talk to you all day. But you started with, I'm not okay if 15 is your goal. When do you decide with rational combination therapy that that there's satisfaction, like we're good? Is it constant improvement, or is it you pick a number with the patient? How do you determine like we're becoming more successful in the combination therapy?
Well, it's up to the patient. I mean, if you had asked me a decade ago how often somebody says to me, my life has completely changed, I was doing well if I heard it once or twice a month. Now I hear it almost every day.
Wow.
I was, in fact, putting together a case for an advisory board that is going to be at one of the meetings, and they asked me, well, put together an acute medication case where the result was dramatic. And I I had a patient yesterday that met
Wow.
that, and she was saying, these medicines are game changers. My life is completely changed. I love them. I'm so happy, and she's not on prevention. She's on optimal acute treatment.
Wow.
So I want to hear that kind of response from somebody. And sometimes I'll have to ask somebody, do we sit tight or do you want to keep pushing? I'm the one that does the pushing if, as we said, if there are 12 headache days per month. But when they're down to once a week, once every 10 days, once every 2 weeks, then the question will be how much further we push, and that is individually determined by a person who's receiving the care.
I love that. And one of the things I've kind of sprinkled into each of these segments is how important it is if you are part of a care circle, your spouse, your partner, your loved one is really, really having symptoms so often that it's interrupting their life, which we know we hear that all the time. Are there any words you can give to a caregiver who's kind of standing by going, I feel helpless. What can I do to help? What can they do? Is it encouraging them for a second opinion? Is it, I mean, just you've been doing this a long time. Is there anything that you can encourage them to do to support their loved one with migraine?
Talking with the practitioner about the burden that somebody suffers with migraine as a neurologic illness is I think, very useful. Richard Lipton in the old days did a study in which he presented to practitioners cases, and in the first instance, he would present the case of the migraine, but not include issues of the impact of the migraine in people's lives, the disability or the impact. And then he would present the same case with the disability and the impact, how the migraine was having effects on people in terms of day-to-day life. And the way the practitioner prescribed was quite different when the patient was described as having impact. My practice changed as a result of a study called the Overcome study, which was an international study done in the US and the EU and Japan of close to 100,000 people with migraine who were asked, why did you go to see the practitioner? And I would have anticipated it would have been the number of headache days or the severity of the headache or the impact on work. It wasn't any of those. It was something called interictal burden. So it was the pervasive effect of the migraine on all aspects of life during the pain attacks and in between the pain attacks. And now I ask patients about what's going on all the time, what's going on at work, home, school, recreational activities. And I think a care provider or a partner can bring that up. And I think practitioners increasingly are going to pay attention to that. And that is my biggest goal. It's to improve the pervasive effect of the migraine in people's lives.
Yeah, yeah. So it's interesting because having that advocate with you who can really describe what they're seeing, it seems like time and time again in studies I've read, that is really important. Even though the partner, the spouse may not want to hear that, they're like, oh, you just sound like I'm a nag or I'm just a burden. Those are such important things, it sounds like. And also because the patients aren't feeling well. They're sitting in your office. Maybe they're having a good day, maybe they're not. But wherever they are too, they're painting a picture of just frustration, and that advocate with them can be so key, it sounds like. And because of what do those off days look like? So
Yep.
thank you for reminding people that's okay. That's okay to, even if you're 10 years in your journey, right? It's okay to say, I need someone to go with me and share what it's like from their perspective. Is that what I'm hearing you say?
Yes, and remember, the more information that the practitioner has in understanding the issues with respect to the migraine that you have, the better. The more they hear, the more motivated I think that they are likely to be.
Yeah.
And I mean, one of the problems I've had over the years is a practitioner will hand an as-needed medicine to a patient, say, see if it works. And the patient will come back and say, yeah, it kind of worked. And that was it. And instead, what we want is the practitioner to say, does this medicine get you pain-free? Is it reliably getting you pain-free? Can you use it when you need it?
Mm,
That might be at work, it might be in a family outing, whenever. And when you start asking that kind of question, people say, well, it gets me pain-free, but I have to wait till I get home to take it because it knocks me out or it gives
right.
me such and such a side effect. Having the more information, the better, I think, in order to get the care to the to the best possible outcome.
Yeah, yeah, that makes so much sense. And at American Migraine Foundation, that's something we want is we want people to have be part of that journey and say status quo doesn't have to be okay. We're going to keep working to find the next treatments. We're going to keep supporting patients where they are. Rational combination therapy is another way of helping people understand that and having talks like this. So, Dr. Tepper, any last words from you before I close this out?
I want to leave you with some hope. I think
Do
this
it.
is a fantastic opportunity to discuss with your practitioner rational combining of therapies. There's no reason why, if you're having to treat migraine 2, 3 times a week on a particular drug, whether it be a monoclonal antibody, whether it be a GPAM, whether it be Botox, why you can't combine and get much better than that without paying the price of more side effects. Same thing on the acute side. There's no reason why you should have to settle for a medicine that you really can't take when you need it, that isn't reliably getting you pain-free, and that is inadequate to your needs. And whether you need a switch or whether you need a combination is something that you and a savvy practitioner should be able to decide together. And I encourage all of you to seek migraine freedom. That's what we're after.
Mm, I love that. I feel like I see a t-shirt in our future. I'm seeking migraine freedom. I mean, this is big. This is huge that people can get to that place of less pain days. So we're going to throw some resources on the chat so that people can go to our website and find other resources at American Migraine Foundation. We're constantly having writing pieces and making sure they're clinician verified. Dr. Tepper is one of the ones who helps us do that as well. So thank you so much. This was fantastic. Great conversation. And for our patients and families watching, we also want to remind you that we have Move Against Migraine, our support group that's closed on Facebook. And I think right now we're at like 67,000 people on that page that are just saying, "Hey, I'm trying this. What worked for you?" Or, "Hey, I'm discouraged. What do I do?" And so we invite you to join that as well. And we'll put that in the chat too. So, Dr. Tepper, thank you, thank you, thank you, thank you for your fight for our patients. And I would just appreciate all that you do for our community too. So, thank you very
Yeah,
much. Thank you for all who watched.
thank you.
Thank you.
Okay.
All right, take care.
Great days, everybody.